Good evening, everyone, and welcome to the DC&R Journal Club. Today, somewhat of a unique group. We'll call it the Best of Michigan. We have a few programs joining us, and I'm very grateful for everyone's time. So, as you're aware, some people are going to join us live. Other people may watch this on YouTube. So this is recorded and will be on the DC&R YouTube channel. To start with, as per my routine, a fun fact about the state of Michigan. So I learned that in 2008, the city of Flint passed a law that gave police the authority to arrest anyone whose pants sagged so low as to expose their underwear or bare bottom. And so I think that is a law that should be adopted across the nation, or certainly across Australia. I'd be very grateful for that. So this is the Journal Club team. Dr. Galandiak is, of course, the editor-in-chief. We're under good leadership. This is our disclaimer. So, of course, our intention is to enhance the experience for both the live audience and the YouTube recording. So please bear with us if the logins are a little bit challenging, but it does protect any hacking and things like that have occurred. So I'm particularly indebted to Dr. Bill Tirocco for organizing this session. I had the pleasure of talking to him online during one of the DC&R editorial meetings and subsequently met him last year face-to-face at ASCARS. And we reflected on different interests, but we found that we both were quite fond of exposing misconceptions within surgical dogma, and hence that's the title of the Journal Club. Now, Dr. Tirocco is, of course, very experienced and quite well-traveled, and so he has been very instrumental in getting the panel together. So he is the special guest, and we will focus on that in due course. But I will get him to introduce the panel, and also we'll take this opportunity for him to talk about the history of colorectal surgery in Michigan, which is quite synergistic, as one of his roles within DCR is overseeing the historical articles that have been published recently. And I think to that effect, there's a quote of George Santayana, and the quote is, "Those who cannot learn from history are doomed to repeat it," which I think is very pertinent, particularly with new technology coming through in colorectal surgery. And so I will pass the microphone to Dr. Tirocco. Thank you.
Thanks, Vlad. And the Best of Michigan title comes from Vlad, but we have 3 of the 5 programs, colorectal programs in the state represented. I wanted to shout out to Dr. Hodema and her program, originally the Ferguson Clinic, Spectrum, and now Corwell West. And the other program is Dr. Craig Reichert, as program director of the Henry Ford Detroit program. The institutions represented the Ann Arbor program, which is a combined program of what used to be St. Joseph Hospital. If you look at our first paper, it'll say St. Joseph's, but it's under Dr. Cleary and his group's article, which is the first one we're talking about tonight. But that combined program is University of Michigan, Dr. McGee representing, and then what now is Trinity Health, represented by Dr. Shanker, Dr. Cleary. The Corwell Beaumont program represented by Dr. Krasnick, Dr. Wasveri, and Dr. Howe. And then what now is the Henry Ford Providence program, previously Ascension Providence, represented by their fellow, Dr. Jay Singh and Dr. Jesnik Buller as program director. So Vlad asked me to do some of the history, and I think it boils down to Louis Hirschman, and I'm going to key in on him. Dr. Nigro has been talked about, and I'll refer you to the January and February 2024 DCRs for much of this and more on Dr. Nigro. Interestingly, this goes back to political upheaval in Europe, this shift from monarchy to more democratic republics. This is Germany before it becomes a state of Germany, 1849. So there's upheaval in Bavaria. So Louis Hirschman, again, his father was 1 year old when Jacob Hirschman was a revolutionary, a failed revolt in Bavaria and a failed revolt up in Kiel, Karsten. So interestingly, these 2 young infants, Karstens and Hirschman, their children would marry, and we'll get into that. But they leave mid-century as there's a huge German influx to the United States because of the upheaval here. This is Frederick Kirschman, who was 1 year of age when he came to this country. He ended up graduating Detroit Medical College, 1873. Karstens, I showed you, was a mentor to him. He was a year or two ahead of Hirschman. And in 1873, there was a plea from smallpox outbreak in the Upper Peninsula. And Frederick answered that call and went up to the UP, married Hannah, both Detroiters, and they moved up and lived their lives up in the UP. Unfortunately, Frederick, who headed a hospital, a mining hospital, as the UP, there's ore and copper found. And he died, unfortunately, best I can tell, from peritonitis, maybe appendicitis. Young Lewis was 7 years of age, and Hannah moved the 6 children back. She was pregnant at the time, to Detroit. So Lewis had religious instruction in Detroit, but spent 7 years in the UP and is born a Uper, as we call him. So he was educated in Detroit public schools and graduated from medical school in Detroit College of Medicine. And he got the bug to do proctology. And he noticed, as most of the founders did, that this was a unheated field. And so he went on to create a department of proctology at Harper Hospital connected to the Detroit College of Medicine. Was the first proctologist in Detroit and probably the state. He became president in 1912 when membership was only 46. He was the 22nd member of our society and the third non-founder to become president. So most of the first 13 would become president in that first decade. So he would influence others that I'll talk about briefly coming up, but he was an incorporator of the board. He was a certificate number 1 in proctology when it was a subsidiary board to the American Board of Surgery, and then was there a member of the board when they gained independence from as recognized by the ABMS. He would retire to Traverse City, which is in the northern part of the state. Continued to have a practice there, and he would high school students would shadow him and go to the OR and such. So he was influential, and many of these folks ended up in medical school as well. He died in 1965, and at the time of his death, Garnet Alt, who we'll talk about, was the sitting president. Norman Nigro was president-elect. So the other person that would become president of our society is Ned Martin, only 2 years junior to Hirschman. He would graduate in 1904 from the Detroit Medical College and then become president in 1928. Another original incorporator, no doubt brought in by Hirschman, became chief of proctology at Harper. Unfortunately, he passed away in 1951, leaving only one member of their department left, and that was Dr. Nigro. Perhaps the most interesting is Dr. Alt, and his profile came out this month in DC&R. He was Canadian, born in Ontario, educated in Ottawa. His father moved the family in 1924 to Detroit as Ford was cranking out the 10 millionth Model T. His father was in real estate, and it was a boom town in Detroit at the time. He went to college in Detroit, but matriculated to the University of Michigan Medical School, and he swam for the varsity team. And he was quite an athlete, and he became a participant for Canada at the Amsterdam Games of 1928 and won a bronze medal 4x200 relay. He would then graduate, return to Detroit from Ann Arbor for surgical training under Hirschman and Martin, and became a proctologist and ended up in Washington, D.C. for practice. He was also present when the board became independent in 1949, and we'll show you a photo later. But this is his mother made the participants from Canada had to come up with their own wardrobe for the opening ceremonies. This is his with the maple leaf on the collar or on the in the pocket. Well, this is his 4x200 freestyle relay team. I stumbled on this on the internet, and this was what got me going on Dr. Alt and and eventually developing this profile. He's standing to the far right. Next 2 slides are going to be the medal, the 9th Olympiad in Amsterdam, and then the next slide after that. So his granddaughter, Margaret Marcellus, lived near Seattle, and she was able to bring those in. I was able to see those medals at our Seattle meeting. This is the board as it became an independent board. Standing to the far right, Dr. Alt, youngest member of this group at age 43, and seated three from the left, Dr. Hirschman at age 71 at this photo. Next slide. And then just want to throw in Dr. Nigro. So Norman Jr. Gave me this. He's an attorney, retired attorney in Phoenix. This is a photo of Dr. Nigro, who's entirely a city boy. So we kind of figured this is up in Traverse City, where he and his son would drive up and see Dr. Hirschman, and they'd go fishing. And Dr. Hirschman is very much an outdoorsman. The next slide. And just briefly, again, I'll refer you to what was written in DC&R a year ago, but Nigro's parents were divorced, very unusual for 1920-ish. And he spent some time, his mother moves to Detroit with the two young children. He spent some time in an orphanage, which was interesting to me. Next slide. I just want to wrap this up with a quote, and this is for you, Vlad. So Dr. Nigro anticipated changes. We know change is eternal. Everything changes at all times. His idea was to react to change, figure out where it was coming, and anticipate it rather than just react to it. And this is a quote from this history of the board. Study of the past may provide guidelines on how to deal with the future. And the quote, and he quotes Eugene O'Neill, which was a famous American playwright, Long Day's Journey into Night. This is from the sequel to that one, Moon for the Misbegotten, where the character says, "There is no present or future, only the past, happening over and over again now." So I thought it was interesting that Dr. Nigro would end his book that he wrote with Harry Gibson on the board with that. So that's gonna finish that history part. And back to you, Vlad.
Thank you very much. Certainly a lot of big names. No, it's great. And I urge people to look out for the history articles. I find them personally very interesting. So our first paper that we're featuring this month is called Ureteral Stents Do Not Increase the Risk of Acute Kidney Injury After Colorectal Surgery. It's a local paper with the senior author being Dr. Robert Cleary, who's kind enough to be with us today. The paper will be presented by Dr. Scarlett Howe, and then we will have Dr. Bradley Crescinto provide expert commentary. So thank you all. Dr. Howe, please start when you're ready. Thank you.
This is Dr. Cleary's paper, and just a little background. The incidence of iatrogenic intraoperative ureteral injuries during abdominal pelvic surgeries in general can be anywhere from less than 1% to 5%, at least based on what's reported in the literature. For most colorectal surgeons, they're going to experience at least one injury during their career. So it makes sense that we have an investment in trying to prevent it. And if an injury does occur, there are better outcomes if it is recognized and intervened as early as possible, namely in the incident operation. So this is the problem. How might we mitigate the risk of iatrogenic ureteral injury? Could we possibly have a solution where we stent the ureters? So far, based on the literature, we are not clearly seeing that there is a reduction in the ureteral injury rate. There is this risk of acute kidney injury, ureteral obstruction, injury to the ureter themselves from the stent placement. But then there's also this question that perhaps if they are stented, at least if an injury does occur, we may be able to recognize them intraoperatively rather than finding out once the patient has been out of the operating room. What Dr. Cleary's team did was perform a retrospective cohort analysis of their center. They included any and all colorectal operations that were open, lab, or robot between the years of 2018 to 2021, certainly all adult patients, ASA 1 through 4. They did include urgent and emergent cases and group them together. However, in cases where there was preoperative sepsis or in cases where the ureter should theoretically not be encountered, such as transverse colectomies or splenic flexure resections, these were excluded. And they had a collection of surgeons for whom some of them they routinely stented and some of them they selectively stented. And so they had a nice sizable cohort to look at both patients that received a stent and patients that did not receive a stent. So their hypothesis was that ureteral stent placement at the induction of anesthesia for colorectal cases is associated with increased postoperative acute kidney injury defined by a change in the serum creatinine. Just some of their key findings: out of a total of 410 patients, 100 did not receive any kind of stent and 300 received some kind of stent, whether that was bilateral stenting, one-sided stenting, and some of them were actually what they defined as temporary stenting, where they received a stent first, had injection of ICG, and had the stent removed rather than left for the entirety of the case. But all stents, regardless, were removed by the end of the case. So none of these p-values, at least in this first table, are significant. They're all greater than 0.1. And you can see that they actually use two definitions. The first is KD, these are all coming out of the Kidney Injury Organization. So a change in serum creatinine greater than 0.3 within 48 hours, or a serum creatinine change of 1.5 times within 48 hours post-op. And then you can see that the percent of the AKI occurring in either cohort, 18 compared to 28, no stent versus stent, there is a difference, but neither of these differences are significant. They also ran analyses where they adjusted the outcome based on parameters that would weight each patient more or less likely to develop an acute kidney injury. So a weighted analysis, so to speak, or adjusted analysis. And again, there is not a significant difference. And then they also report the rate of actual ureteral injury for patients in each group. And certainly since the stented group is bigger, that percent is lower, but again, not statistically significant. And just for our listeners, I summarized basically the 4 patients in each group that had a ureteral injury. And you can see with no stent, 3 of the patients that had a ureteral injury still had identified intraop. They had a suspicion, they were able to place a stent, and then identified that the ureter was injured. The 4th one was identified post-op. And then in the stented group, the 3 cases actually did not have an injury noted or repaired intraoperatively. Only 1 did. So that was just interesting to me, since we are hoping that the ureteral stents would help us identify intraoperative injury. So the main takeaways is that there, at least in this single institution retrospective study, no significant difference in acute kidney injury with stenting. They did do a subgroup analysis with patients who received lighted stents, since these stents are actually wider in diameter and stiffer in order to carry the electronics that create the light. And they did find that there was, on subgroup analysis, statistically significant increase in the acute kidney injury risk with using the lighted stents compared to no stents, and with the lighted stents compared to not lighted stents. But otherwise, the ureteral injury rate and the identification rate was consistent with literature. And so more research always at the end of a project is always needed.
Thank you very much for that wonderful, succinct summary. Dr. Krasnick, thanks for being on the line. Would you like to make some comments?
Oh, sure. Yeah, thanks, Scarlett. And it's a really nice paper from Dr. Cleary's group. So yeah, we're happy we could present it. It's a really nice numbers of with 400 patients, and I think that was really kudos to their group. And it sounds like half their group puts regular stents in and half doesn't. I would say at our practice we do mostly stents for redo pelvic cases and complicated diverticulitis, which I think you had commented on in the paper. We don't have experience with lighted stents, but I think that makes sense that these bigger, wider diameter stents would cause more injury. In regards to the conclusions of more AKI, I know there was no trend, there was no statistical difference when you look at stents versus no stents overall. I will say in our practice, we anecdotally, I do think we'd feel like there's more AKI in the stents population. I can think of a couple in the last few months where they've had very significant oliguria and rising creatinine, fitting your rightful criteria of acute kidney injury over the first 48 to 72 hours. But almost always it seems to be self-resolving, and these patients typically don't need dialysis. So we do find it to be a nice adjunct to our surgeries and to be overall safe. And if it does cause AKI, it seems to be mostly self-limiting. I guess that would be the perspective of Dr. Clear's group as well. I know they mentioned ICG in the stents, and that's a newer thing we've been doing. At least I've been doing a lot more in the last year, where we give ICG via the stent, and then either take the stent out or leave it in. And I think that's a really nice way to identify the ureter and have that kind of ability to feel it if you do it open, but also use Firefly technology to image the ureter. There's plenty of data showing that it's safe and a good way to identify the ureter kind of outside of stenting or with the stent. Either way, it works really well. We actually give 2.5 mils of ICG up the ureteral stent, then flush it with 10 mils, and then we leave the stent in for the case. I mean, we see it just fine with the stent in place, so that if you convert to open or you're doing hand assist, you can still feel the stent and get that kind of feedback, but you can also see it with Firefly. I talked to the residents about as far as stent identification. I think that it does give you that, if you injure it, you'll see the stent, so that's nice, and you can also maybe better identify it with palpation. I will say, there have been times, especially doing hand assist, right, you can give you a false sense of security, especially with the psoas tendon and a really inflamed field. So I think you have to always take it with a grain of salt. Say, oh, I feel it here, I'm good to go, and you still have to kind of really identify it and see the vermiculation or see the ICG. I think is helpful. Just feeling it isn't always 100% not accurate. So.
Thank you very much. We'll open the discussion to the rest of the panel. One of the questions that I have, maybe I'll start with that, is a comment about ureteric stenting reducing operating time, particularly with MIS, where there is no tactile feedback as such. And so I wonder if the placement of stents changes one's technique if the outcome is a change in operative time. Dr. Cleary, what do you think about that?
Happy to answer that question. Dr. Howe, really nice job presenting our paper, and Dr. Krasnick, really appreciate your thoughtful comments. This is a single institution study, and so the results may not be generalizable, and I think that has to be kept in perspective. Practices are different with respect to resources and focus. Our practice is largely robotic. We did 400 robotic operations last year. So, and when you talk about stents for minimally invasive, it's different than stents for open, because for open, you're feeling them. You can use immunofluorescence, but for the most part, you're feeling them. We have robotic PAs who are there for every case and don't rotate off the service, and they are also trained to put in stents. We are all trained to put in stents and put in our own stents, and it only takes us 10 minutes to do it because we do so many of them. We don't consult urology, and so we save that cost. And we no longer leave the stents in the robotic cases. We put them in just a few centimeters, inject the ICG, and then remove them. And we're going to do a follow-up study see if that decreases more so the incidence of AKI. Stents aren't without complications, and if you're training residents, you have to watch them carefully. I was looking the other way a few weeks ago, and one of our residents found the ureteral orifice easily, put the stent up there, and just kept on going. And you can't put it in too far; you'll perforate the renal pelvis. And so that patient got a double J stent, and that healed and is doing fine. But it is important, as others have suggested, that stents aren't without complications. So one of the reviewers on this paper had a thoughtful response. He or she thought that not only are the lighted stents more increased risk, but we shouldn't be using 6 millimeter stents. We should be using 5 millimeter. We use 5 millimeter when we have them. Sometimes they're on back order, and then we have to use 6. But like I said, we're just injecting the ICG now and not leaving the stent in, unless we think there's a high risk for conversion or if the case is open. I do think when you have those resources, and when you're doing them all the time, and when you have a high skill set doing it, then it may be worthwhile doing it. I do think it does save time, just because we see the ureter right away, and you're not constantly looking for the ureter. If you haven't been able to find it, you know where it is, and so just identifying it earlier on, I think, saves that 10 minutes that it takes to put the stent in. Sorry, I probably talked too long, and I don't even know if I answered your question.
No, thank you. That's great. Another thing that I was sort of wondering about, and it seems like you've evolved from leaving stents anyway, but do people put both stents in, or if you're really doing an anterior resection, can you just focus on the left side and therefore potentially reduce the chance of AKI because the other ureter is unaffected?
Sure. I have to tell you that there's 6 of us now who do it 6 different ways, and only one has ever used the lighted stents and still uses them because she likes them. And so, generally speaking, the group, because we're right there and think the risk is low, just go ahead and inject the right side with the 3 cc's of ICG, inject the left side with 3 cc's ICG, take it out, and they're done. I mean, that would be worth studying to see if we only injected one side, would that help, or if we were going to leave a stent, if we just left it in one side. And some of us do that on occasion. For complicated diverticulitis, if we think there's the risk for conversion, inject the right with ICG, and then inject the left and leave the left stent in, not just the right. But I can understand why you think, why would you inject the right ureteral orifice at all for complicated diverticulitis on the left? And I think it's just because surgeon preference, and it's nice to see the right side too. I have seen a right-sided ureter in a minimally invasive operation get dinged when the surgeon lost the forest for the trees in the pelvis. And so, that doesn't happen often, but I think that's kind of what goes through people's minds.
Thank you. Dr. Chirocco, there's an article you wrote, or a letter to the editor, called "Safety First: Exploding the Myths That Prophylactic Ureter Catheters Do Not Reduce Ureter Injuries." Would you like to comment on that, or anything else related to this? Thank you.
So I wrote a review article in AJS, and I found all these quotes, and I put them in the paper. Yes, you can use stents. Young people do it. People who aren't experienced. Surgeons who don't know anatomy use stents. I mean, these things were in publications, and a lot of shaming. I've been in situations and institutions where no one was doing it, but every other month we'd have a ureter injury, and the conclusion would be, well, next time you stents. Well, nobody's using them. So, I came to an institution, started using stents, and I got pulled aside as well. So I think, my opinion, it's one of the things that sets us apart from general surgeons is the preparation for the surgeon, and it's very difficult. I know, Dr. Krasnick, you kind of figure out, okay, which ones should we stent? Turns out you can't predict, and the ones that you think are going to be a breeze is going to be stuck, and vice versa. So the other thing is, we were probably all taught to dig out these ureters. The ureter has a very tenuous blood supply. Just by dissecting it out, you can injure it. 70% of injuries are not recognized. They're found down the road. Some of them are strictures you don't find because they stricture. You've got good kidney on the other side, and you end up with a dead kidney found out years later on the left side. So I think those who write that stents are worthless are those who don't use them. And Gene Silvati, former president, used them routinely for APRs, for instance. And, I think if people, so I was glad Dr. Cleary wrote the paper, and I wanted to support that it may not be ever randomized because you'd need thousands and thousands of patients, but clearly stents prevent injury. The other thing, because I just had an injury not long ago, a few weeks ago, a couple months ago, I saw the patient back today. This was the left ureters in the left gutter, right? So I'm dissecting a pelvic phlegmon, diverticulitis. The ureter is directly midline. It came on a right angle from the left, directly midline. As I peeled it off, I noticed it, had a nick anteriorly. The patient had a double J stent for a couple months. It's out now, and he's all healed. I clearly, it probably would have been a complete transection if I didn't have that stent in, and maybe a resection of that ureter, and maybe needing a Borari flap or something. So it not only, I think, prevents injury, but it limits the amount of injury when you have a situation like that. So that's my take. I'm glad to take the slings and arrows of those who, the non-believers.
Do you take the stents out at the end of the your
Yes.
cases? Do you just in
Yes.
the paper? Okay.
Yeah. Go ahead.
I was gonna say we do as well. I mean, there's
Yeah.
definitely people out there that I've seen who will talk about spasm and they'll do either one at a time or they'll wait 48 hours and then do one at a time. So I've seen that there's definitely a practice pattern of people out there doing waiting a day or two to take the stents out, which I think I get worried that could cause more AKI, but there's some anecdotal
I agree.
reasons.
But very early in my career, I had a case of anuria, and it was spasm on both ureters. And the urologist took the patient back and stented both ureters. So it can happen. It's pretty rare. I've not seen it in 30 years, but it can happen. But no, my routine is to take them out, and usually both sides are stented, Vlad. Whenever that question, but I leave it up to the urologist. And Bob, as far as I know, we talked about it. It's interesting that several programs, at least 3 programs, colorectal programs, teach stenting, and it's great. But the advantage, I think, of having a urologist do the stent is they are now part of your team. And 3 hours later, if you have an injury or a bladder injury or whatever, you can call them and they're obliged to come in and see you rather than scrambling and having an injury that you didn't expect and trying to find somebody in that field to come help you. So that's one thing, one advantage. But I think it's great that we're teaching our young surgeons how to do this.
Hey, Bill, when you called me about this, it said to be a discussant, and you said you do them all the time. I thought, well, I won't be a good discussant because I'm on the other side where I don't do them. And selectively I will. I'm not a non-believer. And but with respect to what you're teaching us historically, when I grew up in my residency, we did all open procedures. It was a lateral to medial dissection, and my mentors use them rarely, if not selectively, and I just carried that on to my practice. And actually, when we moved to the minimally invasive part of it, I actually thought I'm seeing the ureters better than I ever was, even though I wasn't feeling them. Where I got in the transition to minimally invasive, where I thought the most trouble was with colovesical fistulas, where you used to be able to put your fingers in the groove and just kind of finger fraction it out. When you were just cutting across at straight angles, I found I had more trouble with the bladder than I did, in the open period. And with time, that worked itself out. So I do use them selectively, if at all. And of course, the patient safety is always first, but it is a time thing. Unlike Bob's experience where they're doing it themselves, if I board ureteral stents, they're immediately at an hour onto my case. There's no way around it. It's a hard stop on Epic, and there's no way around it. So sometimes I'm not able to board a second case because and so on. So, and I know that's a stupid reason, but I haven't found it to be reduce my operative time because it's a 45-minute experience by the time it's all done. And yet, if you want to learn, you go to your younger surgeons. I go in there and they light these things up with the ICG, and it's amazing. It just all lights up, and it's right there. And then you scratch your head and say, "Boy, I should be doing that every time because it just splays out the anatomy so nicely."
Those are good points. Those are good points, Harry. And I have it all set up for me when I walk in. I don't even have to put it in because the PA is trained to do it, and he puts it in for us. And if I was in a different setting where it would add an hour onto the case, I might very well think differently. And I was trained in your era to dissect between the mesentery and the peritoneum and not get into the retroperitoneum where the ureter is. Now, you can't do that every single time, and there is variant anatomy. And so I think we're going to have ureteral injuries, hopefully a small percentage, no matter what techniques we use. And that's why I said the study isn't generalizable. It's only generalizable to those institutions who want to do it and have the resources to do it, and where it's not going to take too much time.
Yeah, I'll say if you do it routinely, your urologists are doing it routinely, and it takes about, like Bob said, maybe about 10, 15 minutes, even if it's a urologist, because everybody's clued in and, put them in, you redrape and you're off to the races. So
And they're not pleased with me when I bring them in 2 hours into the case after 6 o'clock. They no idea why they're there because I need their help, and then they have to come in. They don't like that either. So that is a negative to not having them on board from the get-go.
Two points on my review. One is with the rise of MIS this century, there's been a threefold increase in the use of ureteral stents. And Sergio Larache had they published down in Orlando, they thought the medial to lateral approach was problematic and maybe increased the risk. And I'll throw that out because there's a couple citations that suggest a medial to lateral having the ureter more at risk than lateral to medial as far as MIS.
Well, I have the privilege of teaching the National Robotics course. I started it with Amir Bastaros in 2011, and we teach the medial to lateral approach, but I'm not married to it. I mean, you take what the defense gives you, and so I teach our fellows, as you probably do too, that is both medial to lateral and lateral to medial, and we go back and forth on it. And you don't go into the unknown. You do what's going easy and don't persist in it. If it's not going easy, you find a different approach. So I think that's important. With a medial to lateral approach, you can go too far. So you go too far lateral, and if you're lateral under the peritoneum, then you're where the ureter are. And so potentially you risk injury if you go too far with a medial to lateral approach. And sometimes with all that great vision, you don't realize it until then you start lateral and go, wow, I went much further lateral than I expected with that medial to lateral approach.
Thank you, everyone. In the interest of time, I think we need to move on to the next article. This is a fantastic discussion. The next article is titled Integrated Agreement of Height Assessment by Rigid Proctoscopy, Rectoscopy for Rectal Cancer. The paper will be presented by Dr. Singh, and then we'll have Dr. Bulla provide expert commentary. Thank you very much. Please start when you're ready.
So this paper is about the interrater agreement of height assessment by rigid proctoscopy for rectal cancer. So a few words on the background. Locally advanced mid and low rectal cancers are treated with neoadjuvant chemoradiation therapy. Most guidelines consider a 12 centimeter distance from anal verge as the cutoff point for distinguishing the upper rectum from the mid rectum. Rigid endoscopy or proctoscopic measurement may be subject to operative variability. Differences of only a few centimeters can potentially alter the management plan. So this is a prospective observation study with the objective of evaluation of concordance of rigid rectoscopic tumor height measurement by 4 different examiners. There were 50 patients with rectal cancer who were evaluated. Tumor height was measured using proctoscopy by 4 different examiners. 2 examined the patients in the left lateral position and the other 2 in the lithotomy position. The tumor palpability and the distance of anal verge from anocutaneous line were also assessed. The reliability between the measurement was assessed with the intra-class correlation coefficient, and the agreement between the categorical variables were assessed with a kappa analysis. So in the results, in terms of the tumor palpability, the interrater agreement was substantial. It was also in terms of the position, it was substantial for the left lateral position, but for the lithotomy, it was moderate. However, the difference was not statistically significant. But we can see that in terms of the tumor palpability, 66% patients, all 4 examiners were able to palpate the tumor, but 34% examiners, in 34% patients, there was some sort of disagreement in the examiners, while all these examiners were senior surgeons. In terms of the distance between the anocutaneous line and anal verge, the reliability was moderate, and it was poor in the left lateral position. It was moderate in the lithotomy, but it was not significant. In terms of the distance of of the tumor from the anal verge, the interrater reliability was excellent, and it was excellent for both lithotomy and left lateral position. In terms of the tumor allocation, more than 12 centimeter and less than 12 centimeter from the anal verge, the interrater agreement was substantial, and it was substantial for both lithotomy and left lateral position. But we see that in 74% cases, all four examiners agreed in terms of the allocating the tumor more than or less than 12 centimeter. But in 26% patients, the tumor allocation was different. The examiners did not agree with the allocating the tumor more than or less than 12 centimeter. So basically, the findings were the interrater reliability of tumor height assessment by proctoscopy was deemed excellent. However, in 26% of patients, there was no agreement on tumor allocation as being either less than 12 centimeter or more than 12 centimeter in height. There was also considerable disagreement in the tumor palpability and the distance from anal verge to the anocutaneous line. The patient positioning itself did not influence the results. So the conclusions were that the proctoscopy may not be a reliable or pivotal basis for considering neoadjuvant chemoradiation therapy eligibility. The height limit overlooks variability in body frame, gender, and the acquired pelvic descent or the peritoneal descent. The eligibility for neoadjuvant chemoradiation should not rely solely on height measurements. MRI or CT scan, which account for other factors alongside height, body frame, and peritoneal reflection, should be incorporated into the decision-making process.
Thank you very much for summarizing this so well. Obviously, this is actually it's an old topic, but it's a hot topic and has always been so. Now, if we can possibly have Dr. Buller to make a few comments. Thank you.
Thank you, Vlad, and thanks, Jay, for summarizing this paper. Very nicely done. So like Vlad said, it's an old topic, and it used to have a big relevance when we used to have this opportunity and set up for rigid proctoscopy in the office. As you see now, most of the offices, we rarely start to do rigid proctoscopy. We have the facility, but to be honest, how many times do I do it in a year? Very rarely. So it's kind of fallen off favor, and that has led to this new fellows not being exposed to doing that in the office and not being trained enough to know its relevance when measuring it. Certainly when it comes to palpating it, like I always count my finger is 8 centimeters, so I kind of figure it out. So, but somebody may have longer fingers, and if they can feel it, that's different. But that's where the reliability stops for me in terms of palpation, that if I can feel it, then I know it. Fixity, which location, that helps me. But our alliance has gone more and more away from our rigid proctoscopy. The problem used to happen when we had EUS. This was a major problem because we would rely on our GI colleagues who were trained in EUS. They would give us a location which would not collaborate. They would overestimate it sometimes, and then we would be stuck. With the MRI, and now we use the MRI rectal cancer protocol, especially for our watchful waiting patients, that has helped us a lot to standardize the way that we now predict the exact location, looking at the peritoneal reflection, and the size and body habitus does make a big difference, and the length of the anal canal and body habitus. Both of these two things, in addition to gender, can make the changes of how and where we feel it. But I do think the MRI has certainly come a long way. CT scan, not so much. You find CT scans being read by radiologists all over the place. What they call as sigmoid is rectum. What they call as rectum is sigmoid. This is across all institutions. But MRI, certainly, if that person, the radiologist, reads it well enough, reads it often, and we have a few radiologists who do that for us. So it has made a big difference in our rectal cancer staging. So we have moved away from EUS, we have moved away from rigid proctoscopy to know the exact location, in addition to the local staging which the MRI offers us. So I think it has been a paradigm shift from rigid proctoscopy to estimating the exact location to now using MRI more and more, because it's just part of our local staging in addition to knowing the exact location.
Thank you very much. I'm going to again ask a few questions. I may direct them to Dr. Chirocco, and then because he knows everyone, he may redistribute as he sees fit. I guess I have 2 points of confusion, and I think they're in a way interrelated. One is, of course, the accurate measurement of tumor height, and the other one is, and I think it's relevant, is the appropriate margin required when doing the resection, because I think we are biased by stating what is the height, because we use that to determine whether a person needs a total mesorectal excision or whether they can get a partial mesorectal excision potentially if it's, upper rectal tumor. That is my suspicion. But the other challenge, you've mentioned you have 8 centimeter fingers, which I'm somewhat jealous of. I think mine are a bit smaller. But when I'm faced with a obese male with a long anal canal, I can't feel anything. And I am somewhat reliant personally on rectal valves to determine a bit of a feel of where things are. So Dr. Chirocco, I know that you've written about this as well in one of the articles. I think it was established of a standard anatomic fixed point of reference to precisely locate rectal cancer will allow uniform reporting and research. I think that was from 2021 in DCR. Yeah. But maybe you can expand on that and then redistribute the questions.
Yeah, I think it's a good place to start because there is no standard. So do we use the anal verge, the dentate line, or the anal rectal ring? And I kind of went through them all in that brief paper, but I think clearly the only clear anatomic, in other words, if you send that specimen off after TME, the only anatomic finding that the pathologist will tell you about is the dentate line. Anal verge is kind of fuzzy. It's where the hair starts. It's where the glands start. And like Jasneet said, it's longer for the male than the female. And I wear 6.5 gloves. So I'm with you, Vlad. I can barely get in there. And Jasneet's way up on the valves. So, but anal rectal ring to me is a relation of the puborectalis to the rectum. It's not anatomic. It only fits for posterior lesions because it's a U-shaped muscle. Anteriorly, it means nothing. So it'd be nice if the community can come together and come up with a standard because you really have to read these papers closely. Yeah, let me throw that out. Harry, do you want to, or Bob? Yeah, go ahead, Bob.
I don't get too caught up in the numbers because they vary from paper to paper. So the ASCAR's randomized trial, LAP versus open, used 0 to 5, 5 to 10, 5 to 15. The Janus trial, for which a lot of our patients go to, and the NAPRC use 0 to 6 and 6 to 12 and 12 to 16. I think a good MR radiologist, I think, gives you a pretty good read of the distance from the anal verge. And I think you combine that endoscopically. We do flex SIGs on all of our patients. And like Dr. Bolshinsky said, instead of calling it a number, it's the lower valve, middle valve, and upper valve. And that gives us a good feel endoscopically, combined with the MRIs at low rectum, mid rectum, and upper rectum. Those who are low and mid rectum are going to stage 2 and 3 are going to be candidates for total neoadjuvant therapy. If it's upper rectum, they may be candidates to go to surgery without total neoadjuvant therapy. But even the upper rectum, if they threaten the circumferential margin, then your MDC may decide to give them total neoadjuvant therapy. Perhaps not all of them, but yeah, an upper rectal cancer we would normally treat like a colon and get a 5 centimeter margin without neoadjuvant therapy. I think that's where all of this goes into, and whether you pick 10 centimeters or 12 centimeters or whether Dr. Buller's finger can get all the way up to the tonsils versus ours that can only get the lower rectum. It's, you know, the finger gives us a lot of information for the low rectal tumors, but doesn't reach the mid rectal tumors. Like everything with rectal cancer, putting all that information together for your decision making. You don't want to happen what happened to us 30 years ago, not having all that, and a gastroenterologist saying, geez, that's a sigmoid cancer. It turns out to be a mid-rectal cancer, and you're caught in the operating room with, what do I do now? That doesn't happen anymore. And that's the point I wanted to make, is that it's surgeon-led endoscopy. We've written that. Others have written that. You don't rely on, we rescope all of our rectal and sigmoid tumors to make sure they are, in fact, where they are. And for the Janus trial, you have to.
I think
Yeah.
Vlad and I discussed the misconception we were aiming at too had to do with TME. And
yes,
if you remember,
can we put the next slide up whilst you're talking? Thank you.
Yeah. So if you think about the 5 centimeter rule, if you go to that paper, there was one patient that had a tumor deposit 5 centimeters from the primary tumor. And so 5 centimeter rule was adopted. Well, that went away years later because we're doing this routinely for one case. And this is Heald's original, this is patient number 6 who had a deposit well below the tumor. Patient number 6 was one patient. And so the thought, I think the misconception was, all that's got to go for every patient. But if you do that and you leave the rectum, the distal rectum for an anastomosis, you have a stripped rectum without mesentery, and that's a problem. And you'll find in Heald's work and others 20% leak rates and nearly 20% mortality rates for some of these cases, remote cases that were done. So now we're back to, the resection. We kind of, the 5 centimeter came down to 2 centimeter if you're in a distal rectum, but should you strip all of it? And I think that was one of the things that we had discussed. If you're going to leave that distal rectum, probably you ought to leave the mesentery. If you're not, then it's going to be a coloanal. And the times that we do TME are APRs and coloanals. But Vlad, I'll throw it back to you, and we can send it around.
Yeah, well, thanks very much. We were fortunate to have Dr. Heald on one of the journal clubs as well, and of course, it's landmark paper, and it's helped teach a lot of surgeons from around the world, and perhaps it's just an error of an illustration rather than anything related to the technique. But I think it is an important point. Now, I guess, unless there are more comments to this, and we can talk about this for a long time, we do have the next segment, which is the discussion of the sort of how to be a good reviewer. So anyone else wanted to add anything to the sort of rectal measurements? Dr. Weisbury, sorry, I don't want to miss out on you.
And when we did our NAPRC accreditation, it helped us to have a more uniform approach. We have the same radiologists down to 4 that read the same things in the synoptic thing, and I guess that's sort of our most objective measurement as opposed to fingers and scopes. But one of the things we did get scrutinized, and what Bob says rings true, trying to rescope all of the rectum and sigmoid, because we got, and that it wasn't a compliance measure, but we said we should do that because we had several times where we went in for a sigmoid cancer and it was rectal cancer, and they didn't get the proper, therapy at that given time, or you aborted the case and took a different direction. So I think, whatever, I think of all this, rescoping your own patients and whatever your measurement is, your finger, your scope, your MRI, just be consistent with yourself.
Thank you very much for that. Thank you everyone for contributing to the panel. Now our next, and I'm sorry we're running a little bit behind schedule. Our next segment is about pearls of wisdom related to what makes a good review and what makes a good reviewer. And Dr. Scirocco is held in very high regard in relation to that. So he is a two-time recipient of the ASCAR's Victor Fazio Award for Editorial Excellence, and also has been a DCR Star Reviewer from 2017 through to 2024. So please, your slides are to follow.
So with apologies, this does not represent DCR. This is my view of how I've kind of stumbled on this over the years. With DCR in various journals. And I can go through this briefly, but basically some of the journals will send you a paper and they'll flat out tell you this is our acceptance rate, and they're usually pretty low. So saying that your bar should be high in reviewing these, just something to keep in mind. What journal are you reviewing for? Next slide. And who is the audience? Is the journal a specialty surgical journal? Is it a GI journal? So the audience matters as far as your review, because sometimes I just reviewed a paper yesterday and it's two of the authors are radiologists and had everything to do with imaging and nothing to do with, okay, what happened when you went to the OR? There was nothing about that. So I thought, well, it probably belongs more in a radiology journal. So keep that in mind, your audience and, international, domestic, et cetera. Next slide. Again, the question at hand, hypothesis, and we saw like Dr. Cleary's paper today, the hypothesis had to do with AKI, and but it's a neat paper because it's AKI, yes, but it's about injury and all these other factors. So great paper. So what's the big question that they're coming to? And sometimes the authors maybe do not recognize it, and you can lead them. So maybe what they didn't think about has become key to you, or a key component, or something that hasn't been said before. So you can help redirect. So as a reviewer, you can kind of play a part in crafting the paper, making it better, and maybe making it publishable. Next. So I go backwards. I read it usually a couple times and spend a couple days and get an idea. What do I think? Do I think it's public? I mean, is it worthy? Would our audience like to see this, or should they see us? And with that in mind, I let's kind of pick this apart and see if there are issues that can improve it. But being worthy of publication to me is big, and sometimes I don't have it figured out, or I think, well, this is not worthy, and I get into the review phase and say, it's not bad. You stumble on something. So does it fit the journal again that you're reviewing for? And then next slide, each of the components I go through. But one way to do is consider yourself a co-author. So you're working with the authors, the team, and you're trying to, kind of like a coach, trying to get this thing to the finish line and maybe smooth it out a bit. Headlines in journalism, there's a thing in journalism about don't bury the lead, meaning get your important point in that first paragraph. Don't save it to the end. And to me, that includes the headline. If there's something really key in that paper, it should be somewhere in the title. So I'll often suggest different titles or just kind of spin on titles. But I go through it. Methods, what comes off is small n, so the patient population, and results can be, you can emphasize that certain points that should be more front and center. And finally, the conclusions, which should bring it all together, including what was highlighted in the title. You repeat things over and over in these papers, and you want to hammer home your point if there is a good one. Next slide. So the setup, I usually not more than a sentence to tell the authors what they've just written. Strengths, weaknesses, adequate patient population, again, whether they did a power analysis, and then the queries. So I'll label the queries 1, 2, 3, 4, 5 potentially, and they should be able to answer those. So if they do a revision, I'll recommend some key points and maybe even like change the title and etc. Next slide. So the top line, accept, reject, or revise. and the editors pull their hair out because they get three reviews. One says accept, one says reject, and one says revise. So, and then you bring in a fourth person maybe to break the tie. But it should be clear in your critique, because in your critique, you're not going to say, well, this paper's no good, go elsewhere. Or you're not going to say, this is great, we're going to accept this. You leave those out, but it should be clear in what you've written, and is whether you want them to revise it, and as far as how many critiques you have, and whether those critiques are fixable or not. When you get the review back, you see the other reviewers' comments, which are a great way for you to learn, okay, what did I miss? What did I get wrong? Or maybe I missed something entirely. And then their points for revision. So the review process doesn't end at your review when you send it in. It ends when it ends, which means maybe multiple reviews if they're revising. Next slide. So transparencies, I remember I've been under, well, I go back to Dr. Beard and being a selected abstractor, to Dr. Fazio, Madoff, and now Dr. Glandiak. I remember distinctly Dr. Fazio telling us, and apparently he had blowback from authors saying, look, I had these 3 reviews and they're not bad reviews. Why did you reject my paper? And Vic would come to us and say, look, you got to be critical. You got to tell them what's wrong if you're going to reject it. You're not telling them you're going to reject it, but you have to tell them what should be fixed, if it's fixable, etc. So the review's got to match what you, even though you don't say it in those words, it's got to match what you think and what you pin it down as far as revision or rejection or whatnot. I spend more time on rejects because I think the authors have done the work. I'm just a critic, so I need to put the work in to tell them if I'm rejecting it, why. And because they may come back, this paper may ultimately be accepted, and they may be able to answer all of my critiques. If they do, great, they're in, depending on what everybody else thinks. Next slide. And then the revisions. So sometimes you have those 4 or 5 critiques, and the authors, a couple things might happen. One is they'll decline to revise it. They'll beat you back on each point. And in my mind, you can maybe 1 or 2, but if I've got 5 points, probably a couple of them are salient. And I don't think they should all be rejected. And the other is you've got 2 or 3 other reviewers who they may have done the same. And in other words, they've absolutely refused to revise it. In my mind, that's they got their chance, and that's that. And sometimes they're right. But usually a couple of points are salient, and they fix it, and great. Your reject becomes an accept potentially, because again, this is a group thought. This is not just one person. So. But it's neat to see. And then in my reviews on the revisions, I'll say, well, I agree with reviewer number 2 because he said this, and you declined it to change it. But you know what? I'm with reviewer number 2. I really think you should change this. And they have the option to do that or not, or they can go to another journal with this paper as well. Sometimes they revise it and they double down on what they've said, and the revision's worse than the original. So my major revision might become a reject on the revision on the second thought. Next. And then my last slide, everything's meritorious. It shouldn't matter who the authors are, but there can be a halo effect or the reverse. There may be negative bias depending on who the reviewer is and where they're at. So there's opportunity for you to step down as a reviewer because there's some sort of conflict, just as the author should expose their conflicts if there is any with industry and such. So it goes both ways. And again, if it's a name player, I'm going to make darn sure that my critique, if I do say reject or say a major revision, that I've got all the ducks in a row, and I'm giving them references, which I try to do anyway. But yeah, there is this thing that the reviewers are anonymous, but certainly the paper and the institution is not. So those are my brief takes, all mine, not DCR. So, but I will credit the Reviewers Guild for bringing our budding reviewers and board members up and about. And I think that was a fantastic idea, and it's really paid off, I think. So kudos to DCR and Dr. Glandiak for leading that, and Dr. Mazaris for leading it. Thank you.
Thank you very much for that. I think those slides are at least they will be very useful for me, but I'm sure other sort of younger reviewers would be in the same boat. And thanks everyone for dedicating their time to this. And as I said before, it's recorded, so share it around. We share it on social media, of course, and hopefully people from across the world will get the use of it. Okay, thank you all. Have a good evening.
Thanks. Good seeing all of you.
Good night.
Thank you.